Welcome, everybody. We're here to discuss strengthening Canadian frostbite care by presenting the initial results of our Canadian Frostbite Collaborative project and our plans for future directions. I'm Cait Champion. I'm a general surgeon working in Parry Sound, Ontario, and I also have an appointment to the Northern Ontario School of Medicine. I've been working on this project for over a year with Dr. Alex Poole and Josianne Gauthier from Whitehorse. And we've been working to build national collaboration around frostbite. And so I'm going to hand it over to Alex and Josianne to introduce themselves, and then we'll get going. Alex?
Hi, thanks, Cait. I'm Alex Poole. I'm a general surgeon in Whitehorse. I've been taking a deep dive into frostbite since 2015, trying to understand what is the best care that we can give our patients with frostbite. And I feel that we've only just scratched the surface, and there's a lot that we need to understand, and that's part of the reason that we're here.
Josianne?
Hi, I'm Josianne. I'm a pharmacist at Whitehorse General. I've lived in the Yukon for a couple of years and have been really enjoying spending some time doing some frostbite research.
Excellent. All right. So without further ado, we will get going. If the slide will advance. There we go.
So much to our surprise, we now have financial disclosures. We've received financial support from the Northern Ontario Academic Medicine Association, as well as in-kind support from the Northern Ontario School of Medicine and the Canadian Association of Wilderness Medicine. We don't have any conflicts of interest, and nor do we have any financial disclosures related to the medications that we may be talking about today. So we have some learning objectives today. Essentially, we would like to identify some of the basics of frostbite care, what we do and don't know, and what we'd like to discover eventually. And the mechanism by which we're doing that is we will discuss the development of a Canadian Frostbite Care Network and what the future directions for qualitative improvement in frostbite care might be. So we're going to go through the background, the methods that we're currently doing with our project, as well as some of the results, and we'll summarize that. And as important as the rest will be the next steps, where we'll hope to recruit some of you to help us with future projects. So frostbite itself, we all have an overall goal to try and take a patient who may look like this at 24 or 48 hours after rewarming and get the ultimate outcome that looks like this. Now, we've all seen patients that maybe they have gotten from that first slide to the second slide with no advanced treatments, but which are those patients? How do we tell which are the patients that might need more advanced treatment, and what might those treatments be? Because ultimately, we would like all of our patients to get this kind of an outcome with what would be described in this case as a grade 4 frostbite with good long-term outcome. Acute frostbite, initially, there's many ways of assessing frostbite, and this is identifying early on that it's not clear exactly how we should assess people. Should it be by grading them visually? Should we be using angiography? What is the role of nuclear medicine, which the nuclear medicine in the form of a bone scan is how we developed the grading system that most of us currently use. But there's many ways that we could potentially do this, and what is the ideal way? Similarly with treatments, there are some treatments that we all do now. We will do rewarming, topical treatments, non-steroidal anti-inflammatories as a means of anti-thromboxane treatments. And what of vasodilators such as iloprost or thrombolytics? And what is the role for those, and what do we really know about them? So are there protocols that we can use? Certainly there are many. And next slide, please. So we do the basics of frostbite care in Whitehorse, and we add iloprost for grades 2 to 4, and 4 we also add TPA, but there's many different ways of doing it. Another excellent protocol out of Helsinki, they give all of the advanced thrombolytics, and the ones that don't respond, they add Isle-of-Prost. The Wilderness Medicine Society guidelines are good evidence-based guidelines, and they demonstrate that there is very little evidence for much of what we do. It's not robust, and thus mostly they'll give expert opinion for some of the advanced thrombolytics. Interestingly, another option is to give hyperbaric oxygen treatment. And there's a good series out of Ottawa. This is a long-term case series of giving hyperbaric oxygen. But fundamentally, what we're all trying to do, if you look at the schematic on the right of this slide, is we're trying to prevent tissue ischemia. Now, whether that's addressing the microthrombi or vasoconstriction post-rewarming or post-thaw, we ultimately would all like to get a good outcome. So we would like to better understand what gets us to that good outcome. Next slide, please. So what evidence is there? Unfortunately, there's a lack of specific large population outcome data in frostbite. And in particular, the current advancements in vasodilator use and thrombolytics is probably running ahead of large outcome data. And certainly because we don't have a lot to offer these patients outside of that, certainly many of us are trying these protocols, but we don't necessarily have good, solid evidence to back them up. Next slide, please. So we set about this project. We'd like to understand best practices, and we recognize there's multiple variable treatment protocols. Some of those protocols have been shown simply by the fact of having a protocol, you likely decrease amputation rate and increase salvage rate, whether you're doing advanced thrombolytics or vasodilators or not. It probably means that you're paying great attention to the wound care, to the early rewarming, and following up with the physiotherapy of the patients. So there are gaps in the literature. Oh, sorry, next slide, please. Predominantly, such as our study, these are predominantly single center case studies, which not necessarily have a good control group. The controls are often historic. And the rural urban distribution is unclear. For instance, us in our northern center, we get a lot of adventure athletes, and these are different patients that have different underlying physiology potentially to some of the urban frostbite patients. Next slide, please. So partially from a talk that I gave last year at the first Canadian Association of Wilderness Medicine meeting, we had a lot of interest in frostbite. A lot of people wanted to help with a better understanding what frostbite care is currently being done in Canada and how we can make it better. And so we decided to develop a Canadian Frostbite Collaborative. And the project has been to understand frostbite patient care needs and current practices in Canada, and really to inform the development of a national quality improvement collaborative in frostbite care. And so where do we start? Where do we go from here? What are the first things that we can try and do? Next slide, please. So we thought it would be useful to look at one of the larger Canadian provinces and see if we can get some actual data, presentation, and outcomes in frostbite. And at the same time, given that we had then been contacted by many people across the country, we thought we would do a survey of interested centers in Canada, both centers that had reached out to us in Whitehorse to understand how to use our protocol. Burn centers are a natural choice. A lot of these frostbite patients in tertiary care centers or cities will end up at burn centers. And so we also, anybody that we identified in that first reach out, or people who then secondarily told us of interested parties, we included them in our survey. And ultimately, many of you listening now, if you haven't been involved with the survey, we're going to keep it open likely until the new year so that we can get more data. And we'll eventually talk about what data we have now. Next slide, please. So the methods that we can do is we are going to look at Ontario. We're going to describe the frostbite presentation and patient outcomes of the data that's available through ISIS in Ontario. Next slide, please. And that data, it should be of interest. So that when we look into this data, what we can get is we can get superficial and deep frostbite and potentially unspecified frostbite, but we can get patient age, gender, and there's other data points that we can get that'll be interesting as well. Next slide, please. So we can look at housing status, what their income status is, which body areas are involved, drug or alcohol exposure prior to their frostbite injury, if they had amputations or other surgical procedures, what time of year this is happening, and what the hospital size was where they were seen and treated. So this should be very fascinating once we get it. Now, with our surveys, we're going to try and identify and describe what's going on now for frostbite treatment in Canada. Next slide, please. So this is all part of our, we'd like to initiate a Canadian Frostbite Care Network. Ultimately, we may all be able to share in these results. We may develop standard protocols or develop studies, and certainly have areas of expertise across the country that can help those who aren't as used to seeing frostbite injuries. Next slide, please. So the survey methods that we've done, these are structured phone interviews, and we have some very keen and able medical students who've joined our project, and they've done a lot of these interviews and subsequently have learned a lot about frostbite as well as some research protocols. And these are all people, the subjects that we interview are participants who've demonstrated an interest or expertise in frostbite care in Canada. And we've done a snowball sampling. So if they tell us about friends of theirs that would be good to participants in the survey, then we would reach out to them as well. So we did get a good cross-section from the country. Most of Canada has been represented, including the territories of most of the provinces. And we did get a bit of a mix of tertiary care burn centers versus rural and community hospitals, as well as physicians and pharmacists, in particular for the advanced therapeutics and iloprost or TPA. There's a real pharmacy network across the country that certainly taps into the expertise that Josianne has developed in Whitehorse for these medications for frostbite. And so at this point, Josianne's going to describe some of the survey results that we have and some of the data that we've come up with so far.
Great, thanks, Alex. So I'll present the quantitative results and describe some of the survey participants' comments as well. The first question asked to the survey participants was about the number of frostbite cases they typically see at their hospital. Participants were asked approximately how many frostbite cases presented to their institution in the last 5 years. 37% responded they had more than 50 frostbite cases in the last 5 years, and a total of 58% said they had 50 cases or less. So basically, this is 10 patients per year or less, which makes frostbite a rather uncommon condition. There was a slightly statistically significant association between hospital size and number of frostbite cases. There was a higher percentage of rural or community hospitals that had 26 to 50 cases over 5 years, whereas a lower percentage of tertiary hospitals or burn centers had 26 to 50 cases over 5 years. But the statistical significance was weak, and this result might be explained by chance alone. So having a low number of frostbite cases is a challenge in frostbite research. It is difficult to gather a large number of patients in a single center and have the power to study the impact of our interventions. The survey participants were then asked about protocols and order sets. Participants were asked if their hospital had a formal frostbite protocol. Half said yes and half said no. When asked what helped develop and implement the frostbite protocol, 6 survey respondents said they based themselves off the Whitehorse protocol. In 2 hospitals, residents were the driver for implementing a protocol. In 1 hospital, it was a large number of frostbite cases of varying severity that was motivation to formalize process, so it's easier to treat. And in 1 hospital, the main driving factor or motivation was a particular severe case of frostbite they had managed. The participants that don't have a protocol were then asked if their hospital had ever attempted to implement a protocol. 22% said they did, but without success, and 78% said they never attempted to implement the frostbite protocol. Participants were asked what barriers they had experienced in developing or implementing a frostbite protocol. There were 3 main barriers identified. The first one was a low volume of frostbite cases. The second one was the access to iloprost and iloprost monitoring requirements. And the last one was the lack of strong interest or leadership or disagreement in care standardization. So the need to monitor patients' vitals regularly during iloprost infusion was reported by several participants as a barrier. Where to administer iloprost, whether in ICU, the emerge, or on the ward, appeared to be an administrative challenge. Participants working in big centers said the criteria for ICU admission was different than in smaller centers, and that the nurse-patient ratio in ICU didn't permit iloprost monitoring. And finding people interested in developing a frostbite protocol and getting different specialty groups to agree together and get involved was identified as a barrier by most participants. It seems like mentalities or perspectives may be different in different specialty groups. One participant said that emerge staff were keen on using medical management, but quote, quote, plastics were just waiting for the toes or the fingers to die off. Also, a participant said that radiologists would never approve CT angio studies because it's not in their wheelhouse. So these are just examples of barriers that people were facing. The third question was specifically in regards to order sets. So participants were asked if they had a predefined set of medication and care orders. The numbers here are similar to the frostbite protocol question. The difference is one hospital said they didn't have a protocol per se, but had an electronic order set that integrated some of the key points. In percentage, 53% had an order set and 42% didn't. Participants were not asked specifically what the barriers were to the creation of an order set, but we can probably hypothesize that the barriers were similar to the ones for implementing a protocol. What we gathered from our participants' answer is we got the impression that people do what they can with the resources that they have at their disposition, but we heard a significant interest in improving frostbite care. The other question pertained to prognostic. Participants were asked if they routinely use a formal grading system for frostbite severity. The majority, 63%, said yes, and 16% said no, and 21% of participants were unsure. 9 hospitals used the grading system developed by Dr. Cauchy in Chamonix, which grades frostbite severity from 1 to 4 using a visual evaluation of the proximal extension of the frostbite injury at presentation before rewarming and skin changes after rewarming. 2 hospitals use a grading system from 1 to 4 similar to burns, and 1 participant reported that the staging of severity was done by the plastic surgeon. In frostbite, radiologic studies can help to determine the extent of tissue involvement, the response to therapy, and long-term tissue viability. In our survey, when asked if participants used nuclear medicine technology in the management of frostbite, 21% said yes, and 58% said no. That result was in big part related to access to the technology, either on site or after hours. Many survey participants said they don't have a bone scan or SPECT CT on site, and sending patients out for imaging is often not feasible. Survey participants also said that getting an MRI fast upon admission was not feasible or practical, and resources were limited. A participant responded that they used nuclear medicine in severe cases only because the logistic can be tricky or take too long to be worth it. Another barrier that came up again is involving different disciplines in frostbite care. A participant reported that getting specialty group involved, such as radiologists or plastic surgeon, was difficult, and that they are sometimes significantly behind with respect to certain technology. Some participants reported that bone scans or SPECT CT were useful to determine the severity of the condition and measure progression. But there was also a perception from others that using nuclear medicine technology wouldn't change the outcomes. Participants were then asked if they used other technologies, such as angio or fluorescence microangiography. In our survey, 21% of participants said they used some mean of angiography. Participant responded they use angio either in severe cases only or to inform on the use of thrombolytics for prognostication and extension evaluation to see if there are any acute thrombosis or pre-intervention by radiologists. 2 sites have considered the use of ICG fluorescence, and 1 site considered the use of laser angiography with SPY system. The main reason for not using angio was no access to the technology. And once again, there was a perception that it would not be beneficial to determining care, nor effective to some participants. The following questions pertain to frostbite treatment, including rewarming, medications, and hyperbaric oxygen therapy. Participants were asked if their hospital had a rapid rewarming protocol. 53% said yes, and 37% said no. 2 participants reported that they didn't have access to water baths or controlled warmers. And only 5 survey participants provided the water temperature used. The temperature ranged from 37 to 43 with a median of 39 degrees Celsius. And only 4 survey participants reported on the duration of rewarming, ranging from 30 to 60 minutes or until the angio suite is ready. Participants were then asked if they use NSAIDs to treat frostbite patients. 95% said yes. What and how NSAIDs were used was quite variable among study participants. 17 participants reported using ibuprofen, 3 acetyl salicylic acid, and 1 ketorolac. According to our survey participants, the dose of ibuprofen varied with a mean of 2,000 milligram a day in adults, and most centers use NSAIDs for an indeterminate duration or as needed. Participants were asked if they routinely prescribe agents for gastric protection along with NSAIDs. 47% said yes, and 40% said no. The proton pump inhibitor pantoprazole was the most common gastric protection agent used. Participants were then asked if they routinely use other pain medications other than NSAIDs. The majority, 84%, said yes. Opioids were the most commonly used pain medications along with NSAIDs. Either hydromorphone, morphine, or fentanyl were used at various doses, route of administration, frequency, and duration. Acetaminophen is also commonly used as per our survey participants. And some participants reported using gabapentin and pregabalin, and 1 participant reported using regional nerve block. Participants were asked if they routinely use topical medications to treat frostbite patients. 84% said yes. And most centers reported using aloe vera. Some participants also reported using silver-based products, such as silver sulfadiazine, unspecified silver-based products, or Aquacel AG dressing. Some participants reporting using the topical antibiotic polysporin. 2 centers reported using topical nitroglycerin, and 1 center Vaseline alone. Participants were asked if they routinely use prophylactic antibiotics. 79% said no. Participants were then asked if they use vasodilators and or thrombolytics agents to treat frostbite. 74% said yes, and 26% said no. Amongst participants that said yes, most used the prostaglandin analog iloprost and the thrombolytic alteplase. 1 center reported using streptokinase, which is another thrombolytic. Another survey participant reported using a combination of alprestadil and papaverine. Alprestadil is an analog of a prostaglandin, the PGE2, and papaverine is a smooth muscle spasmolytic. Looking at the big picture in our survey, 37% of survey participants answered they use both iloprost and alteplase depending on severity. 16% reported using iloprost alone, 11% alteplase alone, and 26% reported using no vasodilator or thrombolytic. This portrait, of course, is just a snapshot of Canadian practices and represents the answers of only 19 participants. Also, the 19 participants were physicians or hospital pharmacists that had either an interest in frostbite care or had a case they needed assistance with. This may, of course, not represent accurately the actual frostbite care in Canada, so we have to be careful in drawing conclusions. But it certainly shows how varied practices are in terms of pharmacologic management of frostbite. Participants were asked if they use anticoagulants and or antiplatelets to treat frostbite. 84% responded yes. Looking specifically at anticoagulants and excluding antiplatelets, in 47% of response, anticoagulant were given a long thrombolytics or vasodilator and 16% a long vasodilator. A total of 37% were giving anticoagulants without thrombolytics or vasodilator. This was either as the only mean of pharmacologic treatment or given for deep venous thrombosis prophylaxis. Standard unfractionated heparin was the most common, followed by the low molecular weight heparin enoxaparin. Dalteparin, another low molecular weight heparin, was also used, according to one survey participant. 2 participants reported using warfarin and 2 participants reporting using ASA. This is the last question on frostbite treatment. Participants were asked if they have access to hyperbaric oxygen therapy at their hospital. Less than half, 42%, said they had access to hyperbaric oxygen therapy. And when our participants were asked if they would use hyperbaric oxygen therapy in the care of their frostbite patients at their hospital, in the ones that have access, 13% of participants said they would use it in the care of their frostbite patients. Hyperbaric oxygen therapy requires time, infrastructure, and as we could see on the previous slides, access to the technology can be a factor limiting its use for frostbite treatment. I will now pass it over to Dr. Champion.
There we go. A little bit of delay, but we got it going. Thanks, Alex and Josianne. So I'm going to discuss the challenges and opportunities in frostbite care reviewed in our survey. So we did ask the questions, the question of whether or not people had access to local experts in frostbite care. And 68% or 13 of our 19 participants said yes, that they did, and primarily felt they had access through on-site specialties such as plastic surgery or emergency medicine. And several participants identified that they are considered the local experts in frostbite care. Next, we asked if people had access to frostbite care expertise outside of their local institution or region. And most participants, although slightly less than the previous question, felt that they did have access to frostbite experts outside of their region who they could reach out to either through specialty networks such as the Canadian Burn Network or individuals that they knew. Cases were typically shared in this case and discussed via either phone, email, or in some cases, text messaging. Next, we asked if people felt that they had sufficient access to frostbite expertise when needed. And despite people feeling that they had reasonable access to local experts or experts in frostbite care outside of their region, 39% of participants, or 7 out of our participants, did feel that they had insufficient access to expertise when needed. And among these participants, it was identified that organized expertise, either nationally or widely adopted protocols or guidelines, would be helpful. So then we asked if people felt there was a need for improvement in frostbite care in Canada, and a whopping 94% of participants felt that there was room for improvement. In general, it was felt that there was a need for standardization of care, which would then have the potential to improve patient outcomes. And there were also some comments that this may also help facilitate procurement of medications such as iloprost, which can be more challenging or require special permission through Health Canada to obtain. And standardization was identified by participants as being particularly useful in lower volume settings where you may not be seeing frostbite as frequently, and those reminders can be helpful. When we asked if people felt there was a need for standardization in frostbite care in Canada, absolutely everyone felt that this was a need. So then we went on to ask about participation in a Canadian Frostbite Care Network, and the vast majority of our participants were interested in this. Although there was one participant who was not, one was unsure, and I think there were some concerns about potential for workload, as I know all of us are very busy, but certainly there's a lot of interest. We did ask people to also identify potential network activities that they would be interested in, particularly research, sharing of best practices, frostbite care education, or other. And the most interest was in the sharing of best practices for those issues of care standardization and consistency, followed by education activities and then primary research. The other category also identified particular interests in education and education outreach. So overall, what have we learned about frostbite care in Canada from this survey? So overall, we saw variability in the use of protocols and order sets. This is interesting and it demonstrates room for improvement in Canadian frostbite care. As Alex mentioned at the beginning, the literature suggests that protocols may improve amputation rate, and the absence of protocols may delay care, which has been shown to be associated with an increased amputation rate. Our survey participants were all individuals with a keen interest in frostbite care, so it's likely that the percentage of sites with protocols in the survey, I don't know why it keeps doing that, is higher than the national average. Again, protocols, I suspect fewer centers in Canada have protocols in place. The protocols in use by our participants were based on the Whitehorse protocol with a focus on the use of iloprost and alteplase, which again is not surprising given our sampling approach. There was a consistency in using the Cauchy grading. Again, this could be reflective of our sampling approach, but may also reflect the ease of implementation for this tool in clinical assessment. Few centers consistently used bone scan or angiography, and as Josianne alluded to, the biggest limitation identified was access and the feasibility of use, and there were also questions raised regarding impacts on the clinical outcome and whether use of these tools truly changed management. Certainly use of these tools is more of a challenge in smaller or rural community hospitals. And so this is something where we're hoping that our ISIS data may help shed some light on where patients are presenting and where we can best intervene to improve their outcomes along their treatment path. Treatment approaches to frostbite were widely variable across centers and even those with protocols in place. And this is reflective of the lack of clear clinical evidence in the literature for many frostbite treatments, particularly the clinical equipoise in the use of vasodilator and thrombolytic therapies. And interestingly, we found that even when it comes to things like reworming, which is, I would say, is considered one of the most established treatments in frostbite, we identified variable implementation in terms of the amount of time used, the temperature, and consistency of implementation. When it came to NSAIDs, we found that they were primarily being used for pain management as opposed to an active treatment modality for the underlying pathophysiology of frostbite, which is interesting. And there was some use of neuropathic pain medications such as gabapentin, but this wasn't seen in all centers. Aloe vera was the most common topical medication used, consistent with the literature, but there was use of others, including polysporin and topical nitroglycerin, which have not been previously described in frostbite care. Variability in the use of vasodilators, thrombolytics, anticoagulants, and antiplatelet agents is again reflective of the variability in the literature, although we did see a trend of more use of iloprost and also plays in combination, which may be reflective of our participant sample and may, as a result, not be extrapolated to all Canadian centers. And then hyperbaric oxygen was not routinely used due to access issues. And again, it'll be interesting to see where patients are primarily being treated when we look at Ontario, and whether access to hyperbaric oxygen may or may not be a factor there. It's great to see that in general, participants feel they have good access to local and regional experts in frostbite care, although identified that there is room for improvement. And there is a resounding interest in standardization of frostbite care across the country and in formalizing access to expertise, best practice sharing, education, and research on a broader national scale. So in conclusion, there is variability in frostbite care across Canada, which is reflective of the variability in the current literature and clinical equipoise in many treatment approaches. We confirmed a need and interest in coordinated frostbite expertise in Canada to overcome these care consistency challenges and the associated variability in patient care outcomes. A national frostbite care network could provide an opportunity to support the development and dissemination of care standards, as well as frostbite care education in general. A network could also help facilitate research across multiple centers to help overcome the limitations in the literature of single center studies with low volumes and variability of patient presentation and care practices. So in terms of our next step, we're planning to have ongoing work on frostbite patient presentations and outcomes in Ontario using the ICES database. We're hoping that this will help us to better understand patient presentations and care needs in frostbite, particularly understanding the needs between rural and urban centers. And we're hoping that this will help us identify targeted opportunities for education and care standardization. When it comes to building a national network, we encourage all of you to participate in an upcoming CALM Mountainside meetup on creating a Canadian Frostbite Care Network on Thursday, November 25th. During the evening, it'll be from 8 to 9:30 p.m. Eastern time, which works out to 6 to 7:30 p.m. Mountain time. And apologies to those of you on the East Coast. We appreciate your willingness to stay up a bit later. As Alex mentioned earlier, this will be a formal part of our study where discussion will be recorded and consent information will be distributed to all participants in advance. We're hoping that these focus groups will help to set the groundwork for creating a national network to further frostbite care, and we're very appreciative of CALM's support and interest in helping to enable this work. As Alex also mentioned, we are still recruiting for our survey. So if you're looking at these results saying, wait a minute, I have so much to add to this, don't worry, you still can. Please reach out to us. Our email is canadianfrostbitecollaborative@gmail.com, and we're happy to set you up for participating in the survey. And so at this point, we're going to open it up for questions. Thanks so much for listening.